Okay, so we'll get started. It's 8:14. We'll get started with Dr. Sternberg's lecture, and hopefully, if you have any questions again, please post them in the question or the chat function, and hopefully she'll be here and we can talk about those.
For the opportunity to speak to you today. I'm going to speak about therapy for advanced urothelial cancer. These are my disclosures. I want to speak about progress, immunotherapy, combination chemotherapy with immunotherapy, antibody drug conjugates, and FGFR inhibition. If you look at the progress in the last 30 years, there really were no new drugs or much happening since the development of the MVAC chemotherapy regimen, and then the approval of cisplatin and gemcitabine. We really were at a standstill for a very long time. Things have changed dramatically now, and if you look over the last few years, we've had approval of 5 new immunotherapeutic agents. 5.
Apologies, we're just trying to figure out this lecture. Give us 1 second. Okay.
5 new immunotherapeutic agents. 5. An approval of erdafitinib, an FGFR inhibitor, and enfortumab vedotin, an antibody drug conjugate. We know that the somatic mutations by tumor type can be very high, and bladder cancer is very similar to lung cancer and melanoma, which is why it does respond to immunotherapy. And with the new classification for molecular markers, we know that perhaps the luminal infiltrated and the basal squamous are those that respond best to checkpoint inhibitors, whereas the luminal papillary tumors are those that may respond best to FGFR inhibition. Now, if we look at the immune checkpoint inhibitors in the platinum-refractory setting after combination chemotherapy with platinum, they have been approved based upon phase 3 trials, phase 2 trials, and even phase 1 trials. We really can't make any head-to-head comparisons among the trials, but we can say, in general, the overall response rate is approximately 20%. And they all have median overall survival that's more or less similar, with grade 3 and 4 side effects, again, somewhat similar. But it's very difficult to compare or make head-to-head comparisons. The first trial was the Atezolizumab trial in platinum-refractory metastatic urothelial cancer. And at that time, it was thought that response and overall survival was dependent upon the PD-L1 status. Those with immunohistochemistry 2 and 3, and you can see from the blue line, seem to be the ones who were responding the best. But very soon afterwards, we realized that actually all patients respond in the platinum-refractory setting, and that the PD-L1 status was not really that indicative. From the Rosenberg data, it looked like the luminal infiltrated patients were the ones who responded the best. But then we had the nivolumab data and other data from checkpoint 275 showing that the basal squamous subgroup were those that responded best. We also know that mutational load seems to be very important in urothelial cancer, perhaps just as important as PD-L1 expression, and that the mutational load is significantly increased in responders versus non-responders. Rosenberg and his colleagues have looked at 60 patients treated on monotherapy immunotherapy trials, and what they saw was that alterations in DNA damage response and repair genes were associated with response to checkpoint blockade and survival, and that patients with DDR deleterious mutations had up to an 80% overall response rate. This is Keynote 45, the randomized trial of pembrolizumab in patients who are platinum refractory who have failed 1 to 2 lines of prior platinum-based chemotherapy. Patients were randomized between pembrolizumab and investigator choice of chemotherapy, either paclitaxel, docetaxel, or vinflunine. Pembrolizumab was given for 2 years. What was seen was a clear 27% reduction in the risk of death. And in the platinum refractory setting, the CPS, the combined positive score, looking at the tumor cells and the immune cells, didn't really seem to make a difference. These data have been updated recently with more than 2 years of follow-up, and you can see that there is a long tail to the end of the curve, and that many patients remain in complete response, many for many years, even though they've stopped the pembrolizumab after 2 years. I have such patients that I'm really very proud to follow. I never saw that kind of responses for that long of a time in the past. The Atezolizumab phase 3 trial was similar to the pembrolizumab trial, but it was designed at a time when they thought that the immunohistochemistry 2 and 3 population were the only ones that were really going to benefit. For this reason, the 2 and 3 population were the only ones that were really going to benefit. For this reason, the way the primary endpoint was designed was that they would look at the overall survival in the immunohistochemistry 2 and 3 population. And if this was positive, they wouldn't do any other statistical analysis. And as you may know, this was a negative study, even though there is a tail at the end of the curve. I'm going to switch now from platinum refractory to patients who are first-line cisplatin-ineligible, meaning they have poor renal function or poor performance status, neuropathy, elderly patients. Most of them have poor renal function. And you can see that the 2 drugs that have been approved are Atezolizumab and pembrolizumab, albeit in different kinds of studies with different numbers of patients and patient characteristics, with overall response rates that are nonetheless somewhat similar for the different patient populations. The same is true of overall survival. For cisplatin-ineligible patients, the indication for both of these by the FDA and EMA has been largely restricted to those patients who express PD-L1, although the US may be an exception. And this is an update of pembrolizumab in the cisplatin-ineligible patients, showing updated overall survival data by CPS score. Here you can see that in patients with a combined positive score of more than 10, there is a difference. those patients actually do better than those with a combined positive immune score of PDL staining that is less. This is the SAUL study that we published last year in European Urology. We enrolled almost 1,000 patients from 32 countries, many patients who were not eligible to enter into the registration trials, patients with poor performance status or low creatinine clearance, on dialysis, brain mets, patients with autoimmune disease or HIV positive were allowed into the study. The primary endpoint of the study was safety, because these patients were actually being denied all chances of immunotherapy. What we saw from this study was that these patients actually didn't do poorly. They did fairly well. Even the patients with autoimmune disease really did rather well. The ones who did poorly were the patients with ECOG performance status of 2. And as we know what happens in these studies, these patients may even have worse performance status than ECOG 2, but are enrolled into the studies. Patients with brain metastases are the ones who did the worst. At GU ASCO in February, we presented results in 23% of our patients that had upper tract urothelial cancer. It was thought that these patients do poorly, that they don't respond to chemotherapy. We wanted to see how did they respond to immune checkpoint blockade with atezolizumab. What we saw in 226 patients with upper tract urothelial cancer, part renal pelvis and part ureteral cancer, was that they responded just the same as those with a bladder cancer primary. These are exploratory analyses of SAUL, but they show very similar efficacy and safety data in upper tract urothelial cancer and bladder carcinoma, providing reassurance that atezolizumab is active and has an acceptable safety profile in patients with upper tract urothelial carcinoma, who generally were expected to have worse outcomes than patients with bladder carcinoma. There are many ongoing first-line phase 3 trials of checkpoint inhibition in combination with chemotherapy, also compared to checkpoint inhibition alone. And while these trials were ongoing, and most of them were completely accrued, the FDA mandated a stop of enrollment of any patients that were platinum-ineligible unless they were PD-L1 positive, particularly into the arm of checkpoint inhibition alone. Although we didn't have an approved diagnostic test at the time, I just want to focus for a minute on the IMvigor 130 study, because we have results from that study presented at ESMO recently, and on the Javelin Bladder 100 switch maintenance study. This is the IMvigor 130 study that was presented at a plenary session at ESMO by Henri Grand last year. Arm A is atezolizumab plus platinum and gemcitabine. Arm B is atezolizumab alone, and Arm C is placebo and platinum and gemcitabine. You can see here the final progression-free survival was statistically significant in favor of the patients who received platinum and gemcitabine with atezolizumab, as opposed to platinum and gemcitabine and placebo. These are interim overall survival data, and they did not cross the interim efficacy boundary for the O'Brien-Fleming alpha spending function. But again, these are interim overall survival data, but you can see there's an interesting trend here. If we look here at the hazard ratios, it looks like that most patients responded, with the exception of the performance status 2 patients. They did well with the combination with atezolizumab. Here, there are fewer patients, but the patients with immunohistochemical 2 and 3 seem to do better. But all of these do cross the hazard ratio of 1. The paper's in press now. I'd like to speak for a moment about the Javelin 100 switch maintenance study. This is a phase 3 study in which patients with locally advanced or metastatic urothelial cancer are treated with 4 to 6 cycles of gemcitabine and cisplatin or carboplatin. If they have stable disease or a CR or PR for 4 to 10 weeks, they were then randomized between avelumab and best supportive care alone, the primary endpoint being overall survival. And we were all quite pleased to see the press release of this trial has met its primary endpoint of overall survival at the planned interim analysis. These important data will be presented in the plenary session at the ASCO meeting. And Matt Galsky has worked with the Hoosier Oncology Group and had a smaller study that was similar that showed an improvement in progression-free survival with switch maintenance with pembrolizumab. I'd like to speak a moment about antibody-drug conjugates. These are monoclonal antibodies conjugated to cytotoxic drug or radionuclide. They improve the potency and effectiveness of monoclonal antibodies and allow for targeted delivery of a toxic payload to the tumor cells, minimizing the non-specific systemic toxicity. The one we've heard a lot about is enfortumab vedotin, the target being Nectin-4, a transmembrane cell adhesion molecule. The linker is protease cleavable, and the payload is monomethyl auristatin E. We were all very impressed to hear Dan Petrolak first present an overall response rate of 44%, including 12% CR and 32% PR in pre-treated patients. And these results were published in the Journal of Clinical Oncology. This is now the first Nectin-4 directed antibody drug conjugate to already receive FDA approval. There's a phase 3 study that's almost or completely enrolled with enfortumab vedotin compared to investigators' choice of chemotherapy, and we'll be hearing those results in the not too distant future. At ESMO, we were all very pleasantly surprised to hear the results of the combination of enfortumab vedotin plus pembrolizumab in patients who were cisplatin-ineligible. There was a 71% response rate. At GU ASCO, Rosenberg updated these results. The response rate is 73% now, with a 15% CR rate, not dependent upon PD-L1 status, with progression-free survival of 12.3 months. And although overall survival was not yet reached, 86% of patients were alive at 1 year. This is a small 45-patient study, but a larger study is ongoing, as are combination trials with chemotherapy. Sacituzumab govitecan is the other antibody-drug conjugate that's being studied for urothelial cancer. The target here is TROP2, a cell surface antigen that's highly expressed by many cancers. The linker here is hydrolyzable. The difference being with a hydrolyzable linker is that you have a payload being delivered not only to the tumor cell, but also to the microenvironment, where there may be tumor as well. The payload is SN38, which is the active metabolite of irinotecan. And there was first a large study with patients with advanced epithelial cancers. And in that study, they had 45 patients with metastatic urothelial cancer that had a 31% overall response rate. At ESMO, Scott Tagawa presented the results of another study, Trophy-1, looking just at metastatic urothelial cancer, where he showed that 74% of patients demonstrated a reduction in their tumor size. And this is a combination of 80 patients that were treated first in the urothelial cohort of the more extensive study, in which we have longer follow-up, plus the Tagawa Trophy-1 study. And you can see that when patients respond to this antibody-drug conjugate, the responses are long-lasting, at least to 52 weeks, with more follow-up in the first study. But putting them together, you can see quite interesting results. A phase 3 study versus investigators' choice of therapy is planned, and this drug has just this week received approval by the FDA for triple-negative breast cancer. This is the fibroblast growth factor receptor pathway. We know that FGFR3 and perhaps FGFR1 mutations are very important in urothelial cancer. FGF23 is essential for phosphate homeostasis, and FGFR inhibition will result in hyperphosphatemia. This is the erdafitinib oral pan-FGFR inhibitor. They evaluated different doses. The dose that was the best was 8 milligrams daily. And looking at 99 patients treated with this dose of 8 milligrams daily, there were 75 evaluable patients with 8 milligrams daily. And looking at 99 patients treated with this dose of 8 milligrams daily, there were 75 evaluable patients treated that had reduction in the sum of their target lesions, an overall response rate of 40.4%, and 37.4% were partial responses. And therefore, this drug too has been approved for patients with FGFR mutations. It was thought that patients with FGFR alterations were not going to respond to immune checkpoint blockade. However, Wang and others have looked back retrospectively on the IMvigor 210 study and the Checkmate 275 trials. It seems to show that this observation is not true. Both patients that are FGFR3 wild type and mutated can respond to immune checkpoint inhibition. I think this is important information to keep in mind. We also know that FGFR inhibition is expected to reduce the immune evasion and increase sensitivity to immunotherapy. There are a number of trials, such as this one, which is a combination of regorafenib and atezolizumab in patients who have FGFR1 and 3 messenger RNA positive urothelial cancer. In this study, patients are randomized between regorafenib and atezolizumab versus placebo and atezolizumab. This study will be presented at an upcoming meeting. At ASCO GU, the North study was presented, which is a similar kind of study with another FGFR inhibitor, or dafitinib, and a PD-1 inhibitor. I'd like to conclude by saying that in terms of advanced urothelial cancer, there's a high mutational complexity with the potential for many neo-antigens that can trigger an immune response. Immunotherapy has definitely arrived for urothelial cancer, both in the first-line cisplatin-ineligible and in second-line therapy for those patients who have failed combination cisplatin chemotherapy. The combinations in first line, the study with atezolizumab and gem and platinum, are very exciting and interesting new data, as well as the switch maintenance therapy results are of extreme interest, and we'll be waiting to hear those results at ASCO. Antibody drug conjugates and FGFR inhibition are also here to stay. Our armamentarium has really increased enormously over the last few years. We have definitely made progress. I'd like to thank you very much for your attention.
All right. Thank you, Dr. Sternberg, so much for that pre-recorded lecture. I'm just going to go through and see. We do have a couple questions, Dr. Sternberg, if you're on and wouldn't mind. Well, let me, for those who have tuned in, just to reiterate, Dr. Sternberg, she's a leading expert in medical oncology, GU cancers, initially conducted her training here in New York City at Memorial. She was out in Italy doing some amazing things out there, and eventually came back to New York, where she's now clinical director of the Englander Institute for Precision Medicine and a medical oncologist at Cornell and the New York Presbyterian System. So we're so fortunate to have her here. One of the first questions that someone had asked Dr. Sternberg, if you wouldn't mind answering, is how do we, as the urologic oncologists, how do we develop the relationship with our medical oncology colleagues to optimize therapy for patients, especially now, even a lot of these immunotherapeutics are being used in the neoadjuvant setting, the adjuvant setting, and all that. How do we best optimize, those types of relationships to kind of better care for our patients? Oh, I'm sorry. I think you're still muted, Dr. Sternberg. Let me see if there we go.
Hello?
Hi.
Can you hear me now?
Yes, thank you.
Okay, great. So I'm in New York City in the rain. I don't know what my background is right now.
It looks nice.
Looks like I'm in Italy, huh? But I'm not. I think that that's a very important question, and I think multidisciplinary teams are what is the key here. Immunotherapy is not only used in metastatic disease and a neoadjuvant setting, it's also been approved for patients even with superficial disease who have failed BCG. So I think that those are patients who usually are refusing cystectomy that have gone on to these trials. And the trial that was positive was the trial with pembrolizumab for patients with superficial disease. It wasn't the topic of this lecture. But I think that the fact that medical oncologists and urologists and radiation oncologists must work together clearly in order to take care of these patients. But not only, once we're taking care of patients with immunotherapies, there could be multi-system problems or side effects. So we need to work with our pulmonary specialists, our cardiologists, our endocrinologists as well, because I think it's really essential. At Cornell, we have a meeting every single Monday afternoon in which the radiologists are there, the pathologists are there, the urologists, oncologists, the radiation oncologists, and we discuss practically every new case that we see. And I think that it's aside from being available whenever by telephone and now by Zoom, I would say, but I think it's really essential that we work together and that the patient, what we do is best for the patient, which is not that it's my patient or your patient.
Sure.
I personally am married to a urologist, so I never had particular problems with getting along with urologists. And I've always had a good relationship since I worked at Sloan Kettering with my urology colleagues. And I hope this COVID will be over soon so that they can start operating again.
Yeah. Well, along those lines, someone was asking, I mean, we are, as a department at Columbia, we have constant meetings about how to, at least the faculty do, not so much the residents, but how to best prioritize surgeries during this time. And along the same lines, for chemo, these immunotherapeutics, all that, what are you guys doing to best strategize, best prioritize patients to receive those? I'm assuming the chemo center, they were not open completely, or if not, they were shut down for a period of time and thinking about opening up. How are you guys dealing with that?
During COVID, I had a Zoom conference yesterday with there were 60 people on the line that were prostate cancer experts from all around the country, not just New York. And what I understood clearly was that all around the country, patients and doctors are suffering, and that research in oncology has been put aside for research in COVID at this moment. And so but not only we at Cornell, also at Columbia, even at Sloan Kettering as well, have put aside the enrolling patients into new clinical trials. I would say maybe we could say that we need those clinical trials to move forward, but since they haven't proven to be effective, some of the therapies such as adjuvant therapy for bladder cancer after a patient has had chemotherapy in the neoadjuvant setting and they still have muscle invasive disease, there's no known treatment that is really approved for these patients. So we are enrolling patients into a study for these patients with pembrolizumab versus observation. That's one of the ongoing studies. And we're not allowed to do that at this very moment during the COVID crisis because both Columbia and Cornell, as you know, are part of the same system. And but it's not just our hospitals, it's all over the country, not enrolling new patients into, let's say, unproven therapies. But we are allowed to continue even experimental treatments that are ongoing in patients that have already been enrolled. This is countrywide, and I hope it's short-lived. We all hope it's short-lived. But that's what is really happening now. And most of the operating rooms, particularly in New York City, have been taken over as intensive care units for patients with COVID. And our surgeons are unable to operate. And going back to the multidisciplinary approach, I work with our surgeons every single day. And if they're unable to operate, they're unable to evaluate patients, they're unable to send patients, My urologist has 70 patients on his waiting list to operate. He's
Yeah.
operating, but he has to appeal to the hospital board of directors for every case that he wants to operate.
Sure.
So, I mean, they've taken up the ICUs all over the country for the COVID patients, and we really do hope that this, at least this wave will be over soon so that we can get back to normal, because all of the hospitals are suffering in the
No,
country.
it's true. I mean, we see it daily too, and we're trying to kind of pick the best strategy to now select patients that would benefit the most from having their operations as soon as possible.
Of course.
Just to go along to kind of go back to the pre-COVID era, one of the issues with these small molecule inhibitors, the monoclonal antibodies, has been cost. Cost of these for the patient, cost per cycle, all that kind of stuff. How do you see costs fitting into? I mean, if we start seeing major benefits, whether it's neoadjuvant, superficial, adjuvant, for the metastatic setting, what have you, how do you see cost playing a role into overall delivery of this care?
I don't know that I'm the best one to discuss costs, since I've worked in a public health system in Italy for over 30 years, and I've just been back here for a year and a half, and I don't know that I understand all of the costs, but I think that many of the medicines that I discussed were in the context of clinical trials, and I've used many of these drugs in the context of clinical trials where there usually is no particular cost to the patient. Once they are FDA approved, the majority of these drugs are paid for by Medicare or by most insurance company, but that's not all the drugs. And we find problems with some patients having high copays and they can't necessarily pay. And that's something that's it's new to me. It's a kind of an anathema to me after having worked in the public health system. But I'll say that drugs that were approved in America, we've had the FDA inspect our place in Rome, Italy, and the drugs were approved the next day in Italy. For instance, abiraterone for prostate cancer. We didn't have access to that really in Italy for another 2 years. So whereas the public health system, in theory, takes care of everyone, it takes care of everyone at a different level than in the United States, where there's access to many, many more drugs for more people. Obviously, we can see what's happening also in the COVID crisis, and what happens all over the world is those people who are more indigent do have less access. Even if they have Medicare or Medicaid, they have less access to physicians. They trust physicians less. They have more comorbidities, and they do have less access to the drugs. But I don't think I'm the best one to discuss that particular aspect.
It's no problem. It's just something I think, during residency, we are not exposed to any sort of the cost aspect of care. And it's something, because the field is changing so much, it's something I think people are interested in learning about. Along the same lines, I think a lot of the residents are very interested, if you don't mind, for those who decide to pursue a career in urologic oncology, and a lot of their patients kind of enter this realm of medical therapy for some of their cancers, what kind of side effects, complications associated with these immunotherapeutics should we look for? What are the most common, and how can we best optimize? I know one of our urologic oncologists in our department works very closely and sees patients with our medical oncologists on the same day. So they optimize care that way, but that doesn't happen all the time. So for us who don't necessarily know what goes into the day-to-day with regards to providing these therapies and the side effects, what should we look out for?
Most of the immunotherapies, in terms of giving the immunotherapies, I don't think that most urologists are really that interested in themselves giving the immunotherapy, from what I understand, because they are intravenous treatments. They're usually given either every 3 weeks or every 4 weeks, depending upon the immunotherapy. And they're usually, to my knowledge, given by medical oncologists up until this point, at least. Even the patients with superficial bladder cancer, who were absolutely refusing to go on to cystectomy after failing BCG, I was the one treating those at Weill, Cornell, those patients. So I don't think that the urologists they'd rather be doing surgery than
Sure.
taking care of these patients, but they are still responsible with the medical oncologist for these patients. If they have side effects, they will be calling their urologist as well as their medical oncologist. So they obviously need to know about all the side effects. And I think that what's been incredible for me is first the immunotherapies. They don't work in everyone, but when they work, they can be really highly effective. But one must be aware if someone, for example, one of the more common side effects could be pulmonitis.
Yeah.
And especially in this day and era where pulmonitis is something we're all really scared about. How do you tell the difference between a COVID pulmonitis and a pulmonitis due to immunotherapy?
Mhm.
And I think that the pulmonitis due to immunotherapy often is not accompanied by a fever. It's a little bit different pulmonitis. And when you stop the immunotherapy, it often goes away. And in some patients, you can re-challenge them again and they won't have it again. But in others, you can re-challenge them and they will have pulmonitis. So that's been the worst side effect for me in patients who are responding beautifully. As I mentioned with the pembrolizumab data, patients who, like with metastatic disease, even to the liver, maybe I should have shown some of those CT scans. I forgot to do that. But even to the liver, I have patients who are off treatment for years and they have complete response that's very, very long lasting. I mean, I've never seen that with any chemotherapy that we used in the past. So I think that's a remarkable breakthrough for those few patients who do respond so very well. All the immunologic side effects can occur, like colitis. That's why patients with ulcerative colitis or colitis are usually not put on these trials, although we showed that patients with rheumatoid arthritis and colitis can, if they're well controlled, receive therapy with atezolizumab in the SAUL trial. And patients can get pancreatitis, hypophysitis, myositis. I've seen like one of each of these things.
Sure.
And working with your endocrinologist is really essential. We always have to measure thyroid function when we're giving these drugs as well. So these can cause these different immunologic side effects. Many of them are endocrine or myositis even. And I think that the most common are perhaps the pulmonitis that we've seen. But there are other side effects as well. And I think that when a patient is on immunotherapy, we need to be very aware of these. What's happening now in this era of COVID is that we are pushing some of the patients out who are responding well. They're not necessarily coming in. We're letting them skip one immunotherapy dose because immunotherapy actually lasts a very long time. And we feel that probably even the patients on trials, we're not compromising that much by letting them perhaps skip one dose, not coming into New York City just right now. And if they skip one dose, probably they'll continue to be responding. And we don't really know if we give immunotherapy and we increase the T cell response, if those patients might even have a better chance of fighting off COVID, or if they will be more compromised. We don't really have enough data yet to know that. Chuck Drake at your institution at Columbia, who's an immunologist, thinks that perhaps we will increase their ability to fight off infection by increasing their T cell responses. It's one hypothesis.
Yeah, no, it's an interesting one, and you can just take advantage of this time to kind of expand on that idea. I think it's great.
Yeah.
Well, Dr. Sternberg, thank you so much. I mean, it was truly an honor to have you and Dr. Bachner with us today for this Empire lecture series that we started for residents to kind of take advantage of the didactic aspect while we are, out of the operating room. So thank you so much. Please stay safe right across the park from us. And for everyone else